Greetings. I'm Alan Lewis, and I'm the Dean of the School of Health Professions, and welcome to our fifth lecture of the Dean's Lecture Series for the School of Health Professions. I just wanted to, before we get into today's topic, I wanted to take an opportunity to have a little bit of a status check, just to sort of touch base on where we've been thus far and where we're going for the remaining sessions for this particular series. So today is our fifth lecture. We had planned 9 actual lectures, and so we're just beyond halfway. And so I want to say that if you missed any of the earlier lectures, please feel free to contact Franchon Jackson in the School of Health Professions Dean's office and ask her to send you the link for the recordings of the previous lectures, because you can certainly look at those at any point. And on occasion, we've actually had a handout or two as well, so Franchon can provide that to you. And I just wanted to mention that a lot of the content that I'm using in these lectures is from a book I wrote in 2014 called We're All Racist, The Truth About Cultural Bias. We Are All Racist, The Truth About Cultural Bias. So we can also make a courtesy PDF copy of the book available to you as well. Just ask Franchon and we'll send that to you via email. That'll give you a little bit more background and context about the content that we're talking about in each of these lectures. So I wanted to remind you that the reason for doing these lectures is really to provide an opportunity for primarily our students at Downstate, of course, the students in the School of Health Professions, but also the students in all the other schools and colleges on campus, to learn a little bit more about culture and learn about the role culture plays in the delivery of healthcare services, so that they themselves, because they'll be working in a world that's very diverse culturally, will be much more effective in managing their caseloads and working with the people that they're providing services to, who will be very different culturally. So we wanted to make sure that we had an opportunity to have some of these conversations. And it's also timely because of some of the things that are happening in our challenging world these days. You know, back in 2020, we had some social unrest and some racial issues going on. So it seemed appropriate for us to launch this particular lecture series at this particular point in time to make sure that our students have a grounding in cultural understanding that will help them as healthcare providers. We also are trying to evaluate this session. So I've asked Franchon to send out for each of these sessions a very brief evaluation instrument. It's just a few questions so that we can hear what you thought of the session and what kinds of things we can improve on going forward. We always want to know what our participants think, because we want to engage in continuous quality improvement going forward and make sure that we continue to do things that make this lecture series better in the future. So if you have, we would like you to give us your voice in terms of how you think the sessions are going and how helpful they have been, and what things you have gotten out of them, and what things you may be able to, we may be able to do differently to make them better. So let Franchon know. I think she's going to automatically be sending those evaluations to everybody who has signed up to participate in these lectures anyway. So without further ado, let me go ahead and start our conversation for today. Remember, we use a sort of a 30-30 format. What that means is up to 30 minutes for the first part of the time together, where I'll give some basic information and overview of the topic, and then up to 30 minutes for the second half of our time together, which really will be a time for us to engage and have a conversation, answer questions, make some observations, and the like. I will say that we are in the academy, and of course, in the academy, we don't all have to agree. So there may be things or points that you want to make that may be different from points that I'm making. Feel free when we get to that second segment to make those points. It's good not to have group think. We're all free thinkers and critical thinkers in terms of engaging with material and thinking about it differently. So we want to make sure that we have an opportunity for everybody to chew on the information and engage with it in a way that's unique to your own point of view, and to express those points of views. So again, what I'm presenting really is just sort of based on my experience and my reading and my research and what I've done over the years, and clearly is not the only way to think about these topics. So today we're talking about the role of culture in social determinants of health and health equity. So again, the role of culture in social determinants of health and health equity. So before we jump into talking about what that role is, let me just make sure that we define the appropriate terms that are part of that topic statement. So the first one is culture. And of course, our first session we did in this series spent a fair amount of time talking about the concept of culture. But culture really is the traditions, the customs, the ways of living that are synonymous with a particular group of people. So within a given group, a group defined by whatever cultural dimension you want to think about, it could be race, could be ethnicity, could be religion or spiritual orientation, could be sexual orientation, could be political affiliation, could be discipline. Any of those dimensions of culture will be relevant. And culture really speaks to the fact that within that group, within a given group defined by a cultural dimension, there is a certain lifestyle, a certain set of customs, a certain way of living, a worldview, if you will, a set of assumptions that the people within that culture sort of embrace and have some agreement on, at least some consensus perspective on. And so that's the concept of culture. So culture then becomes a concept that both unifies groups when you're in the same group as somebody else who shares your cultural dimension that you're talking about. It's also a concept that can delineate groups, because across cultural lines, there are differences in worldview, differences in values, differences in perspectives. Clearly Republicans and Democrats have a different worldview. So within a Democratic cultural orientation, there's some similarities. When you look at that orientation versus, say, Republican orientation, there are clearly some differences. So culture then becomes just a way of thinking about those similar ways that we view the world, the values, the assumptions we make, and the worldview that we have within a given group where people share that same cultural orientation. Now, I did mention early on in one of our earlier lectures that most of us have many cultural orientations. So you have the cultural orientation that relates to who you are in terms of race and ethnicity or nationality. You have an orientation that relates to, if you are so inclined to have a spiritual orientation, you may have a different cultural orientation in that particular area of your life. If you have a professional life, have a career, then obviously there's a cultural orientation related to whatever you do for a living. There's certainly a culture that relates to where people live geographically. There's certainly a culture that relates to a political affiliation, and on and on. I mean, so there are many different dimensions, and within a given person, it's possible to have multiple cultural affiliations depending on what area of one's life we're talking about. So culture, though it's a simple concept, it can be very complex, because we as individuals can be fairly complex in terms of the many cultural orientations that we have. So culture, again, just speaks to the traditions, the customs, the assumptions, the values that are synonymous with a particular group that may differ across cultural lines in another group. So health. What do we mean when we say health? Well, the World Health Organization says that health really is physical, mental, and social well-being. So it's much more than the absence of disease. It really is taken to the next level, saying a person may be free of disease, but also has a certain amount of well-being or optimal functioning in the areas of in the physical domain of one's life, and one's social domain, and one's mental health domain. I tend to think a little bit broader than the worldview, than the World Health Organization's view. They talk about physical, mental, and social. I embrace a whole person model that was propagated by an addiction guru named Sharon Wakeshire Cruz. And I think she presented her model back in the 80s, so it's been a long time that it's been around. But she talks about health in terms of dealing with persons who are recovering from addiction or trying to overcome addiction, and having to have some balance in one's life across 6 different domains. She talks about it in terms of the physical domain, the emotional domain, the mental domain, the spiritual domain, if you have one, or whatever you call the domain that deals with life's meaning, sort of existential kinds of issues. The social domain, I'm not sure if I mentioned that, and the volitional domain, which is your free will. So again, that's physical, mental, social, emotional, spiritual, if it relates to you, or whatever life's meaning is to you, and volitional. And so I think about what Sharon Wakeshire Cruz says, which is full functioning and balance across those 6 domains within a given person. But the basic concept is that it's more than just free from disease to consider yourself healthy. It's really having a full life, well-being, and full functioning in whatever domains you see yourself functioning in as a person in terms of your entire life experience. Health equity. So health equity really speaks to the fact that everyone has a fair opportunity to be healthy. By fair, it means that not that everybody has the same opportunity, but that people have opportunity that relates to whatever their needs may be. And needs are very individualized. So a person who has more health needs, clearly, if they are achieving health equity or living in a situation where they have health equity, then they have a set of services that address maybe the disproportionately more needs that they particularly have in a given area related to health. So health equity speaks to the fact that not everybody has the exact same thing, but people will have their health needs addressed based on whatever degree of disadvantage a given individual has in terms of their health needs. And so the opportunity matches that person's disadvantage, and it's supposed to offset that disadvantage in terms of achieving health equity. So there's no negative influence of things like social determinants, which we'll talk about in a few minutes. It's still sort of the inverse of health disparities. And it really is the absence, health equity really is the absence of all avoidable and modifiable differences in health. So anything that can be changed or that's subject to change is no longer impeding that person's health status if that person has health equity. So it's really the fair opportunity to have a full health experience and to be healthy, and to actually, if you have a health need, to have that health need be addressed in a way that you don't just get what the next person gets, but you get whatever you need in a very individualized way to offset whatever your particular situation is. And if you have a disadvantaged situation, then maybe you need more services or more resources to offset that health need to ensure that you have the opportunity to have health equity or positive health. Health equality is a similar concept, but health equality speaks to the fact that everybody basically has the same opportunity to be healthy. So it's essentially a level playing field. And if a person isn't healthy, then everybody gets the same amount of intervention or services to make them healthy. So it's all equal, health equality, which is a little different from health equity, because health equity talks about a person receiving what he or she actually needs to offset whatever his particular or her particular disadvantage is in terms of health. Health equality really is a precursor to health equity. So in other words, in order to have people have health equity, the first step is to make sure that you have a situation where there's health equality. In other words, there's a level playing field, and you have the ability to offer people health services that are equal across the board. And then you move to health equity, which says, okay, health equality is one thing, equal services for everybody, but health equity means that the person's needs drive what he or she receives in terms of health services to ensure they have a fair opportunity to be as healthy as possible. So health equality is a little bit different. Social determinants of health really speaks to those societal conditions that do overlap. They're based on society's context that influence everybody's living, but that tend to disadvantage certain groups. So we're talking about things like lack of access to healthcare, poverty, inadequate housing, lack of transportation, low education, food deserts, inadequate food options. So these are the conditions that exist in society that disproportionately affect some groups more than others. So they're social conditions, and they tend to help determine a person's health status, whether a person has health equity or health inequity. So the social determinants of health really are those social factors that are interrelated, they sort of overlap, and raise additional challenges for a person of a certain orientation culturally when it comes to health equity. So, obviously poverty, lack of employment, lack of access, housing issues, all the sort of the ills of society, the social ills of society really do impact health for particular groups in this country. So, Franchon, put the model, if you will. So what I did last night is I tried to sketch. I'm a big fan of visual models, visual conceptual models. So last night I said, let me just see if I can draw a picture about the relationship between culture and health, culture and social determinants, and culture and health equity. Okay, that's good, Franchon. Pull it down just a little bit. There you go, perfect, thanks. Very good. Okay, so this is a conceptual model that I just drew up last night real quickly to kind of help depict and convey some relationships here related to the role of culture in social determinants of health and health equity. So just to orient you to what I sketched here. So on the left side, you have two circles, one inside the other. So the larger circle really is the circle that has the label on it, social determinants. So that's a broader context. So just think about that bigger circle that's really being society in general. And within that larger circle, you have these social determinants. So you have income, education, transportation, housing, all those kinds of things that are social determinants. And when they're negative, they become social determinants of health for certain groups. And then look at the smaller circle where you see some writing, you see culture, you see race, ethnicity, and see some other dimensions of culture in a smaller font there. So what I was trying to convey here was that whoever you are, which is that small circle, in terms of your cultural orientation, really lives in the broader context of society where the social determinants are all around you. So all people live in that small circle that says culture and the things below it. And so what you see is that I made a distinction in that circle between of the things that are cultural factors between race and ethnicity and the other dimensions of culture, which are things like sex, gender identity, language, sexual orientation, spirituality, political affiliation, and so on. And I mentioned some of those earlier. Because the fact of the matter is that race and ethnicity is really the only aspect of one's cultural orientation that another person or that society can actually perceive and make a judgment about, for the most part. It's not always clear what a person's sex is, or a person's gender identification, or a person's language, unless you engage with that person, or their sexual orientation, or their spirituality. If you just pass a person on the street, you have no idea what those other more hidden cultural dimensions are of that particular individual. Typically, you don't. But when you pass that person, if you have the ability to see that person and perceive that person visually, you can pretty much make a judgment about his or her race or ethnicity. So really, it is the cultural dimension of race and ethnicity that really is all important when it comes to thinking about social determinants of health and health equity, because that's the piece about who we are as individuals that the world reacts to. When you see me, you don't know my sexual orientation. If you just see me and don't talk to me, you don't know what my language is. You don't know what my spiritual orientation is, or my political affiliation. You don't know what my career is, or my job, but you can clearly see me and see, okay, Black male, and you can make that determination. Whether I agree with it or not, you can make that determination. And so the bottom line is that it's, of all the cultural dimensions we have, it's really the race and ethnicity, which is the perceivable dimension in terms of other folks, that really does impact the social determinants and the health equity and health inequity. So what we're talking about here is whoever you are, whoever a person's, whatever I should say, a person's racial ethnic orientation is, because it's perceived by the world, there's certain biases around that, and that interacts with those various social determinants. So it's clear that people who are of color, who have a racial and ethnic orientation of persons of color, typically have more negative social determinants. So typically have more poverty, less formal education, more housing issues, or less stable housing, less stable transportation, less access to healthcare. All those social determinants that overlap tend to negatively, disproportionately impact persons of color more than they do other persons in our society. So culture then impacts social determinants, because culture relates to that in terms of who you are, race and ethnicity wise. And what it means is that if you have a certain orientation, then those social determinants could and have a high likelihood of being more negative for you in terms of the populace of people, the masses of people. So there's really a correlation between a person's race and ethnicity, that particular dimension of culture, and how those social determinants impact that particular dimension of culture. So the role of culture and social determinants is one of a correlation. It's sort of a positive correlation. Whoever you are in terms of race and ethnicity tends to, across the big group, not always true, because there are always individual exceptions, but within the big group, you see more poverty among persons of color. Within the big group, you see more housing instability among persons of color. You see more problems with transportation. You have more problems with adequate access to healthcare. You have more food deserts in communities that are lived in by persons of color. So you can see that the cultural piece in terms of race and ethnicity really is very prominent in terms of understanding how those social determinants impact a person. And when those social determinants are negative because of a person's cultural orientation, that means their health status is likely to be negative as well, or not to be optimal, I should say. So culture and social determinants really have that correlational relationship, where there's a one-to-one correlation between one's race and ethnicity and the extent to which social determinants have a negative influence on that person's life across the whole population. Again, not talking about individual exceptions, but across the whole populace of people within a given race or ethnic group. And then, of course, culture impacts health equity in terms of, it could be either health equity or health inequity, because the culture going through the social determinants, because the social determinants really are the context that we live in, And so that's sort of an intervening variable or moderating variable from the whole research vernacular. So then the culture then, because it's perception based in terms of race and ethnicity, in terms of that particular dimension or those two dimensions, really does influence how a person's health status, because the person's health status is related to the social determinants, whether they're negative or positive, which relates to their cultural orientation, race, ethnicity, and then the health status becomes sort of the downstream dependent variable, if you will, or result of that person's race and ethnicity interfacing with those social determinants. And then the person has a relative amount of either health equity or health inequity. So what we see is a relationship between culture and health equity that's really a pretty direct relationship, with exception of social determinants being sort of the intervening moderating factor that further can exacerbate the health equity or health inequity, whatever it ends up being for the person. So again, the relationship that we look at in terms of culture with social determinants and with health equity is one of a correlational relationship, where there's typically a very direct pattern of what you expect to see when a person has a certain cultural orientation, meaning race or ethnicity in this case, and how those social determinants impact that person, and then whether or not that person has health equity or health inequity. In other words, whether they have a fair opportunity to have a full life and full functioning in the major life domains of health, or whether there's some disadvantages or some difficulties or challenges that person is seeking in the sense of health inequity. So it's pretty simple. The culture, primarily race and ethnicity, because that's the piece that's perceived. So it's all perception based. And we know that we live in an environment that has a lot of bias. One of the things we'll talk about, I think in the next lecture, when we talk about health disparities, is the fact that most of the prominent health disparities models say that health disparities or health inequity, two similar concepts, health disparities and health inequity, same kind of thing. They say that most of the challenges there have to do with the fact that that people have bias in terms of providers. There's two levels of bias. There's provider bias, a healthcare provider's bias that may be conscious or subconscious. And then there's bias implicit or inherent in the system in terms of how the system is designed to function and who is designed to serve. That's also involved. So bias is a very strong force that helps the perception-based aspects of culture either be positive for a person who is in a majority group, or not so positive for people who are in groups that are minority groups or persons of color groups. And so the bias piece is very important in addition to the perception. So again, just for a quick review, culture, the main piece of culture that impacts with social determinants and health equity is the perceivable piece of a person's cultural orientation. That tends to be race and ethnicity. And depending on what that race and ethnicity is, you have a certain relationship with those social determinants across the whole population in terms of those general patterns. Again, not talking about individual differences, that can be exceptions, but we know that there's a disproportionately higher number of persons of color who have housing instability, who have financial issues, who have lack of access or low health insurance, low rates of health insurance coverage, who have transportation challenges. So that those determinants become negative depending on your cultural orientation. That's the correlational relationship between culture and the determinants. And then the culture impacts the health equity, whether it's actually equity, which is a positive version of having access and opportunity to health, or whether it's health inequality, or rather health inequity, which really is more the health disparity side of things, which is a really challenged situation where the person's not having a fair opportunity to have optimal health at all. So with that, I'm going to stop and let us move to our second segment for our discussion component, and we'll see how things go with that aspect. See you on the other side.